Hello, everyone, and welcome to the UVA Medical Center Hour. I'm Justin Mutter, the director of the Medical Center Hour, which is a program of our UVA Center for Health, Humanities, and Ethics. We're delighted to offer today's event as part of our Medical Center Hours series on history of the health sciences. These lectures allow us to explore key topics in the history of the health professions that strongly influence today's clinical practice and clinical education. Today is a virtual only format, so when it comes time for questions at the end from our participants, please use the Q&A tab at the bottom of your Zoom screen. It's a truism that all history shapes our present, but arguably the 2 to 3 decades immediately following World War II in the United States were more defining for contemporary nursing and medicine than any other period in the 20th and 21st centuries. Many of our current institutions and administrative processes were founded and developed during this formative period. The establishment of the modern hospital system, the advent of Medicare and Medicaid, the spectacular growth of medical technologies and pharmaceuticals catalyzed by unprecedented federal investments in our research enterprise. To these themes, Professor Dominique Tobbell's new book, Dr. Nurse, Science, Politics, and the Transformation of American Nursing, adds an extraordinary contribution to our understanding of the evolution of the health professions and its education during this post-war era. Professor Tobbell is the Centennial Distinguished Professor and Director of the Bjoring Center for Nursing Historical Inquiry at UVA School of Nursing. She is the author of many books and many essays that explore the complex political, economic, and social relationships that developed in the post-war era after World War II between universities, governments, and the healthcare industry, relationships that continue to impact modern-day health systems. She is the recipient of numerous academic awards and fellowships, and currently serves as a board member of the American Association for the History of Nursing. During our moderated discussion following Professor Tobbell's presentation, we will be joined by Professor Beth Epstein, who is Associate Dean for Academic Programs at the UVA School of Nursing. An international expert in many aspects of nursing practice, including clinical ethics and theories of moral distress, Professor Epstein is a prolific contributor to academic nursing education and scholarship. I look forward to our discussion. And to start us off, I'm delighted to welcome Professor Dominique Tobbell to our Medical Center Hour stage.
Thank you, Justin, for that generous introduction and for inviting me to share my work here today. And thank you also to Charlene Kaufman for facilitating this and Peter Conklin working behind the scenes. So it's a privilege and honor to be here today. And I'll start. The country's more than 3 million nurses represent the largest segment of the US healthcare workforce. They are referred to as the backbone of the American healthcare system, spending significantly more time with patients than any other member of the healthcare team. The nursing model of care, which centers on the nurse-patient relationship and on improving health among individuals, families, and communities, is underpinned by a distinctive body of knowledge. For the past 60 years or more, nurses have conducted research contributing to that body of knowledge that has shaped healthcare practice, informed health policy, and improved health outcomes. Yet in the 21st century, many people, including those who work in healthcare, and perhaps many of you here today, are still surprised to hear that nurses do research and that research is underpinned by a distinct body of knowledge, nursing science. And furthermore, relative to other types of health science research, nursing research is poorly funded. And nurse scientists, nurses who have earned a PhD either in nursing or one of the biomedical, behavioral, or social sciences, often reflect on the importance of identifying themselves as a scientist rather than as a nurse in order to be taken seriously as researchers and avoid conflict with their physician research collaborators. In other words, despite more than half a century of experience as researchers, nurses' status as scientists is still contested. My new book, Dr. Nurse, describes and analyzes what I call the academic project, the efforts of American nurses to establish nursing as an academic discipline and nurses as valued researchers in the decades after World War II, and considers why in the early 20th century that academic project remains incomplete. So the book describes nursing's academic project from the 1950s through the 1980s over the course of 5 chapters, plus a conclusion that brings the history forward into the present. And as I argue in the book, the work to establish nursing as an academic discipline included raising the educational level of nurses, creating and demarcating the boundaries of a distinct science of nursing, and establishing nursing PhD programs to prepare new generations of nurse scientists. For these nurse educators and researchers, establishing nursing as an academic discipline was essential if nurses were to better care for the changing health and illness needs of the population. Today, I'll walk us through some of the major aspects of this history. Along the way, I'll highlight several of the implications of this history for nursing and healthcare today. So to begin, we need to go back to the 1940s. Nursing faced a crisis in the years after World War II. The arrival of new technologies, potent pharmaceuticals, and complex surgeries had made patient care increasingly complex. The regimented, procedure-based training of hospital-based diploma programs that had predominated in nursing education before the war was inadequate. Nurses often found themselves without the availability, knowledge, or authority to provide appropriate care to critically ill or dying patients. Studies conducted in the late 1940s and early 1950s documented the crisis in hospital nursing and predicted that between 50,000 and 75,000 new graduate nurses were needed each year. But rather than tackle discriminatory hiring practices, salaries, or working conditions, issues that might have improved job satisfaction among and thus expanded retention of nurses, nurse leaders, hospital administrators, and other healthcare leaders focus on how to produce more nurses by expanding and reforming nursing education. Beginning in the 1950s, nurse educators introduced Bachelor of Science in Nursing, or BSN programs, located on university and college campuses. This new model of nursing education emphasized science-based learning, clinical thinking, and patient-centered practice. Integrating the biomedical, behavioral, and social sciences, as well as emphasizing nursing theory and patient-centered practice, the BSN prepared nurses for their new role as expert and independent practitioners. By emphasizing the health perspective rather than a disease perspective, by considering the patient holistically, and by prioritizing the agency of the patient in shaping their health, nursing and its science sought to stand apart from the reductionist model of medicine that emphasized disease, diagnosis, and cure. By the 1960s, nurses who had undergone advanced clinical training at the master's degree level assumed new advanced specialty practice roles in areas that included psychiatric nursing, maternal child health, oncology, nephrology, and critical care nursing, as well as nurse practitioners providing primary care. Now, 2 elements of the broader context are important to acknowledge here, and they build on what Justin's introductory comments. First, nursing's academic project took place in the context of the changing character and mission of American universities. With the establishment of the National Science Foundation and expansion of the National Institutes of Health after World War II, the federal government became the primary patron of basic research. In response, universities increasingly prioritized research, and particularly the acquisition of federal research funding, over their teaching and service missions. Faculty were rewarded for securing research grants and collaborating with industry, generating patents and publications. At the same time, the federal government and its policymakers ensured that graduate education, particularly at the doctoral level, became an integral component of the nation's research enterprise. Second, nursing's academic project also occurred as many academic health institutions were being conceptualized or reconfigured as academic health centers, or AHCs. These are institutional umbrellas that combine a university's health science schools, biomedical research institutes, and affiliated teaching hospitals and clinics. They were established to increase coordination and improve efficiencies among the health science schools and between the university and its teaching hospitals. AHCs were also designed to dismantle the disciplinary silos that had previously characterized the health sciences. So AHCs were therefore intended to promote interdisciplinarity in research and education and a team approach to clinical practice by integrating nursing, medicine, dentistry, pharmacy, public health, and other allied healthcare. And policymakers also looked to AHCs to coordinate the supply and distribution of healthcare professionals within a region. By the late 1970s, academic health centers had emerged as a dominant institution in American healthcare. And it's in this context, nurse educators sought to secure nursing's legitimacy and status within research universities and academic health centers by shifting their focus to engaging in research supported by external research funding and establishing the academic status of their discipline, nursing science. And as part of this, beginning in the mid-1960s, a growing number of nursing schools introduced nursing PhD programs to prepare new generations of nurse scientists able to conduct the clinical research necessary to advance nursing science and improve patient care. Now, as nursing embarked on this academic project, it faced a series of issues and challenges. And 3 of these challenges proved especially determinative in shaping today's nursing education and practice. First, how would nurses construct their discipline? That is, what types of knowledge and research questions would they focus on? And which research methods and theoretical frameworks would they draw upon? Second, as nurses committed to raising the academic preparation of nurses, how would the profession maintain accessible pathways into nursing for students from underserved and historically marginalized communities? And third, how would academic nurses working within academic health centers balance their school's responsibilities for education, research, and patient care? So for the next 30 minutes or so, I'll talk about how academic nurses work to resolve these issues, highlighting along the way some of the limitations of nursing's academic project and the legacies that continue to impact nursing today. At the outset, it's critical to state that nursing's academic project was indelibly shaped by race and gender. During the formative years of nursing's academic project, only those with first a BSN, then a master's degree, and eventually a doctorate were invited to contribute to the science of nursing. And since the introduction of trained nursing in the late 19th century, healthcare and nursing education, as well as higher education in general, were segregated in the Jim Crow South and heavily circumscribed by racial discrimination in the North. Black, Indigenous, and other women of color, as well as men, regardless of race, face significant barriers accessing undergraduate and graduate nursing education. And because of ongoing systemic racism, these racialized barriers continued even after passage of civil rights legislation in the 1960s. So this meant that nursing's academic project was advanced primarily by white female nurses. This slide shows that the first generation of federally funded nurse scientists were disproportionately white. So about 95%, a little more than 95% identified as white, with only 3% identifying as Black or African American. And this was when African Americans constituted about 11% of the American population. And this lack of diversity impacted the development of nursing science, shaping what were and were not considered important areas of research, a topic that I'll touch upon later. So first, how did nurses construct their disciplines? From the late 1950s through the early 1980s, academic nurses constructed a science of nursing that would provide the basis of nursing practice. They did so not only to improve patient care, but also to secure their roles within the post-war research university. Nursing science was to be distinct from, yet complementary to, the biomedical sciences that underpinned medical practice and research, particularly its focus on the identification, diagnosis, and treatment of discrete diseases. By contrast, nursing and the science that informed it would move beyond, quote, merely treating disease entities, as sociologist Francis Cook McGregor wrote, and would treat, quote, patients as total persons. By establishing nursing as an interdisciplinary science that integrated psychological, cultural, social, and physiological understandings of health, illness, and the patient, nurses could claim distinctive knowledge, skills, and expertise. And this expertise was rooted in an understanding of patient behavior and attitudes. And this was expertise that nurses and not physicians would contribute to the improvement of patient care. But as nurses grappled with how to distinguish nursing science from the theory and knowledge of the disciplines it drew upon, it really grappled with the kind of distinguishing nursing science from these disciplines, particularly anthropology, psychology, sociology, and the biomedical sciences. During the 1950s, 60s, and 70s, a small group of nurse theorists, some of whom are shown on this slide, worked to demarcate nursing's empirical focus, establish a theoretical frameworks by which nurses could understand and influence patient health, and distinguish nursing science from the biomedical and behavioral sciences. The theorists identified 4 concepts that would define nursing's empirical focus: the whole person, so not simply the locus of disease or disability; health, as opposed to disease and its treatment; the influence of the social and physical environment on an individual's health; and nursing, that is, what nurses do for and with patients to enable and support patients as agents in the pursuit of their own health goals. In this way, nurse theorist Rosemary Ellis wrote, "Nursing moved from doing for patients to working with patients, helping people to care for themselves and involving them in their care and decisions about their health." In addition to transforming patient care, this focus shaped the kind of knowledge produced by nurses and distinguished it from knowledge produced by physicians and biomedical research. And not incidentally, by the 1970s, the concepts of the whole person, the environment, and health had broader political significance. A growing array of activists, including Black and Latino health activists, disability rights activists, and women's health activists, criticized the paternalism of physicians and the harmful reductionist model of medicine that emphasized disease, diagnosis, and cure. Activists, nurses, and physicians joined with this growing array of other health activists who called on their colleagues to focus their attention on the problem of healthcare for the poor, and particularly the compounding effects of racism and poverty on health. Now, as academic nurses were constructing their science, academic physicians were establishing the discipline of clinical epidemiology and asserting the superiority of the randomized controlled trial for generating the most objective and reliable knowledge. They did so in the context of the quality assessment movement in healthcare, which aimed to systematically measure the outcome of patient care. This would help determine which clinical interventions worked and which didn't, and hold physicians accountable for those outcomes. And this was referred to as outcomes research. The primacy of the biomedical sciences, the growing importance of outcomes research, and the broader quality assessment movement in healthcare shaped the ways in which research methods and evidence they generated were evaluated and accorded status. The randomized controlled trial had become the gold standard of research method in clinical medicine by the 1970s. But nurse scientists instead preferred descriptive quantitative studies, observational studies, and qualitative research methods that relied on the invocation of theory rather than statistical analysis as a means of validation. As a result, the knowledge their research generated occupied a comparatively lower position in the so-called hierarchy of evidence. And this led to nursing science and nurse scientists being undervalued within academia and the health sciences, even as nurse scientists researched the impact of nursing interventions on patient outcomes. In other words, they were doing outcomes research that was focused on improving the quality of healthcare. For example, nurse scientists investigated ways to reduce hospital-based infections and adverse drug interactions, and to improve end-of-life care, pain management, and the management of chronic illness and disability. Moreover, nurse scientists contributed to clinical research what was missing from physicians' interventions-focused approach: evidence into the social and political context of patient care that could help explain why individuals made choices they did about their own health and health care. Despite being undervalued, nurse scientists who are increasingly educated in nursing PhD programs did secure their place within the post-war research economy, securing external research funding, disseminating their research, and establishing research centers, even during a time in which women scientists in general fared especially poorly. Historians of gender and science have described the post-war demise of predominantly female disciplines such as home economics, and analyzed the efforts of women scientists to establish themselves within traditionally male disciplines previously closed off to them. The establishment of nursing science and the experiences of nurse scientists thus provides new insights into the experiences of women scientists and the intersections of gender, knowledge production, and discipline formation in the post-war decades. Now, turning now to the second challenge that confronted academic nurses in the decades after World War II. As nurses committed to raising the academic preparation of nurses, how would the profession maintain accessible pathways into nursing for students from underserved and historically marginalized communities? By the 1950s, there existed multiple educational pathways into nursing. In the 1950s, hoping to resolve the nursing shortages, nurse educators had introduced one-year licensed practical or LPN programs and two-year associate degree programs. In the resulting educational hierarchy, LPNs were tasked with the so-called traditional bed and body work of nursing, while associate degree educated nurses were to have greater clinical responsibilities than the LPN, but less than that of the BSN educated nurses. The BSN prepared nurse assumed the status of the so-called professional nurse and the responsibilities of the expert and independent clinician. Professional nurses, typically after completing an advanced graduate education, would go on to serve as clinical supervisors, educators, or administrators. Now, diploma-trained nurses, those trained in hospital schools of nursing, were expected to complete a BSN in order to be considered a, quote, professional nurse. But it's important to note that despite this hierarchy, graduates of associate degree, diploma, and BSN programs all sat for the same licensing exam to earn the title of registered nurse. And these hierarchical demarcations were usually blurred in the day-to-day clinical work of nurses. This educational hierarchy, however, exacerbated existing hierarchies within the nursing workforce that stratified nurses by education level, family income, class, and which were further compounded by race and the effects of segregation and systemic racism. As this slide shows, by the early 1970s, the majority of Black nurses graduated from LPN, associate degree, and diploma programs, and this subsequently limited their opportunities for career advancement, leadership, and faculty positions, all of which required at a minimum a BSN degree. I realize not listed here are the LPN numbers, and in like 1969, 15 to 20% of those training to be practical nurses identified as African Americans, so definitely overrepresented. So although some nurse leaders regarded the different educational pathways as hindering nursing's professionalization, the persistence of these pathways indicates their value in increasing access to nursing for underrepresented populations. It also highlights the varied interest and political power of nurses and other stakeholders in maintaining them. For example, during the 1960s and 70s, the American Nurses Association and other nursing leaders pushed to close diploma programs and established the BSN as a minimum credential for professional practice. But this was at a time when state and federal policymakers prioritized expanding access to and diversity within higher education. And in this context, state legislators were persuaded by the arguments of diploma and associate degree educated nurses to keep and even expand the educational pathways into nursing because it fit their goals of expanding access to higher education, as well as addressing the healthcare needs of the state. In Minnesota, for example, state legislators were under pressure from nurses to facilitate educational mobility for graduates of diploma and associate degree programs. These legislators in turn put pressure on the University of Minnesota as the state's land grant institution to resolve the problems of educational mobility. For example, through the creation of accelerated RN to BSN programs, the awarding of college credit for prior education and clinical experience, or enabling nurses to complete challenge exams to test out of classes that covered knowledge they already had competency in. In April 1971, State Representative Vern Long wrote to the University of Minnesota's Vice President for Legislative Affairs, asking the university to help resolve difficulties nurses had faced in their efforts to attain advanced education. Long chaired the Minnesota House's Higher Education Committee and was vice chair of the Appropriations Committee, so he had a bit of power here. He asked the university vice president to direct your immediate attention to the problem. If in fact the solution to these problems can be found, then I want to say in the most forceful manner I know how, let's have the answers forthcoming soon. The following year, Long asked the University of Minnesota Dean of Nursing to report on, quote, the progress you have made in the areas of those nurses that are trying to upgrade their education. The issue of educational mobility that was then politically charged. As University of Minnesota nursing faculty member Mariah Snyder recalled, quote, because of the 2-year programs being in rural communities or outstate, legislators were not going to do away with the schools in their cities. The Minnesota Nurses Association was also opposed to restricting access into professional practice by closing diploma or associate degree programs. After all, Snyder noted, the Minnesota Nurses Association's largest membership was 2- and 3-year grads, so they weren't going to get behind this effort to close 2- and 3-year programs. As a result, the state's registered nurses and the legislators who represented them expected the state's 4-year colleges, and particularly the flagship University of Minnesota, to take the lead in facilitating the educational mobility of the state's nurses. The intersecting interests of nurses and state legislators thus helped to shore up nursing's educational system as one characterized by differential pathways into nursing. Now, through the late 20th and early 21st centuries, nurses and healthcare organizations continue to debate the merits of maintaining these differential pathways. In 2011, the Institute of Medicine, which is now the National Academy of Medicine, called for the proportion of nurses with bachelor's degrees to increase from 50% to 80% by 2020. It did so in response to more than a decade's worth of compelling evidence that hospitals with higher percentages of BSN-educated nurses had better patient outcomes. Nevertheless, the Institute of Medicine recognized that the associate degree remained a critical entry point into nursing, particularly for people from rural areas, disadvantaged backgrounds, or from historically marginalized communities. 5 years later, the National Academy of Medicine reaffirmed the importance of maintaining and strengthening the educational pathways into nursing. But to be sure, these educational pathways have not resolved the problem of racial inequities in nursing. This is especially true within academic nursing, where 82% of full-time nursing faculty are white. Indeed, ongoing systemic racism has meant that Black, Indigenous, and other people of color continue to face barriers accessing higher education in nursing. And this is reflected in the continuing marginalization of women of color in low-paying, low-status direct care occupations such as nursing assistants and home health aides. Much more work is needed to address these racial inequities and increase diversity within nursing, particularly at the highest educational levels. An essential component of this work is to provide support and resources for educational mobility within nursing, so from the role of home health aide all the way to the advanced practice role, via articulated educational pathways and the implementation of career ladders. As I noted at the beginning of my talk, the lack of diversity in nursing, especially among the first generations of nurse scientists, shaped what were considered important areas of research. As Lucille Davis, a faculty member at Rush University, asserted in 1974, nurse researchers from racial and ethnic minority groups, quote, bring a unique perspective to the research process. Davis saw it as absolutely essential that we have more nurses from minority groups trained as researchers if nursing is to develop research models relevant to the healthcare needs of minorities. Davis was joined by other Black nursing leaders and the newly established National Black Nurses Association in calling for increasing the proportion of Black nurses and other nurses of color and advancing research to increase the body of knowledge about healthcare and the health needs of patients of color. But throughout the 20th century, nursing schools struggled to recruit and retain doctoral students and faculty of color because of persistent structural racism. And this has had long-term implications for nursing science. By the early 1990s, there remained a dearth of nursing research on the experiences and nursing care needs of patients of color. Indeed, more than 8,000 clinical studies were published in the US nursing journals between 1983 and 1981. But as nurse scientist Eileen Jackson reported, only 59, that's 0.7%, included African Americans in the study sample. And the majority of these 59 studies did not focus on the 8 major health problems identified among African Americans, nor did they address the reasons for or propose solutions to disproportionately high morbidity and mortality rates in Black communities. Jackson concluded, simply including marginalized groups in the study sample does not make the research relevant to the health of those being studied. And these legacies continue into the present as ongoing racial inequities in nursing significantly undermine nursing's ability to address racial health disparities and structural racism in healthcare. So in these final minutes, I'll now turn briefly to the third issue that confronted academic nurses in the second half of the 20th century. How would academic nurses working within academic health centers balance their responsibilities for education, research, and patient care? So one of the consequences of nursing's academic project was an essential severing of the relationship between nursing education and nursing's practice base. When nursing education moved into the university after the war, education and practice were, for the first time in nursing's history, separated. Nursing faculty rarely held clinical appointments in the teaching hospital's nursing service, and some educators believed a strict separation between education and practice were essential to establishing nursing as an academic discipline. In other words, nursing faculty were discouraged from being clinically active. In the 1960s, some nurse leaders saw the cost of this approach and worked to reunify education and service. But they faced significant institutional and political barriers. nursing deans at a handful of academic health centers sought to bring academic nursing close to the structural model of academic medicine, whereby faculty would be clinically active and hold an appointment in the teaching hospital or clinics. In this model, nursing schools would have responsibility for and authority over the quality of nursing education, care, and research that took place in the university's teaching hospitals and clinics, so equivalent to the academic medicine model. This would also ensure that nursing had an equal and parallel role to the other health professions within the academic health center. But these early unification efforts made clear that academic medicine had its limits as a model for academic nursing. Most significantly, nursing faculty, unlike their colleagues in medicine, could not be reimbursed for nursing care services. Because physicians billed for the services they performed and reimbursed by third-party payers, they had the ability to generate substantial clinical income for medical schools and academic health centers. Nurses, however, were salaried employees and were not directly reimbursed for their services. Instead, the costs of nursing care were wrapped into the total cost for hospital services. For nursing faculty to be compensated in their clinical practice required that nursing deans and faculty negotiate individually with the hospital and other service agencies. But as neither public nor private insurers directly reimbursed nurse practitioners, clinical nurse specialists, or other advanced practice nurses for their services until the late 1990s, to say nothing of reimbursing registered nurses, these negotiations invariably generated mixed results. Thus, at least until the late 1990s, academic nurses who engaged in clinical practice had no mechanism for generating income for their schools. The revenue for most nursing schools instead came from state support, tuition, and grants. And without a mechanism of generating clinical revenue, it has been difficult for nursing schools to justify, let alone prioritize clinical research, even as nurse leaders recognize the benefits of having a clinically engaged faculty. The absence of nursing faculty from teaching hospitals also meant that they had little contact with physicians, which disadvantaged them as they sought to claim their rightful place as equals within the interprofessional healthcare team and within academic health center governance. Nursing leaders had hoped that unification would promote interprofessional collaboration within academic health centers, but the outcomes were usually mixed. For example, a unification model was introduced at the University of Rochester at the founding of its academic health center in the early 1970s, and was intended to facilitate collaboration with physicians and other health personnel. The parallel structures at the clinical chief level were particularly important for planning, implementing, and evaluating the specialty programs in patient care, the education of nurses and physicians, and research. However, according to Loretta Ford, who was founding dean of the University of Rochester School of Nursing, the effectiveness of those interprofessional collaborations ultimately depended on, quote, the personalities and styles of the medical and nursing chiefs and the availability of resources. Some medical chiefs, all are men, Ford explained, recognize nursing as an independent, autonomous professional group, which forms a basis for effective collaboration. Other medical chiefs, however, view nurses as handmaidens to physicians, and this had led to friction and conflict. In these situations, the physicians struggled to adapt to the parallel organization structure and instead considered themselves, quote, in charge and responsible for everything, including nursing. Thus, as academic nurses worked to rebuild the connection between education and practice and establish academic nursing as parallel and complementary to academic medicine, they confronted resistance from physicians, as well as hospital administrators, who were all too comfortable with the gendered and hierarchical status within academic health centers. These structural limitations and interprofessional politics continue to impact nursing and healthcare today. In 2016, the American Association of Colleges of Nursing reported that academic nurses have, quote, minimal, meaningful participation in health system governance. The AACN cited the tuition-dependent structure of academic nursing as a barrier to full integration and concluded that most nursing faculty have been unable to develop robust faculty practices. And as such, academic nurses are, quote, not positioned as a partner in healthcare transformation. So to wrap things up, despite these limitations, by the end of the 20th century, American nurses had made substantial gains on their academic project. They had developed a science of nursing that underpinned a patient-centered model of care. The nursing model considers the patients holistically and in relationship to their environments, attends to patients' physical, psychological, social, cultural, and emotional needs, and prioritizes the agency of patients in shaping their health. So too, nurse scientists had demonstrated their capacity to conduct patient-centered research that shaped healthcare practice, informs health policy, and improves health outcomes. The legitimacy of nursing science was reflected in the establishment of the National Center for Nursing Research at the NIH in 1986, followed by its designation as the National Institute of Nursing Research in 1993. At the end of the 20th century, the NINR was critical to raising the legitimacy of and amount of funding available for nursing research in the US. As American nurses established their discipline and secured their roles within research-intensive universities and academic health centers, they navigated the institutional and gender politics of higher education and the interprofessional politics of healthcare. As such, and as I think I've shown today, this history reveals the impact of disciplinary, institutional, and interprofessional politics and the shaping of those politics by gender and race on the making of a new discipline. It also highlights the importance of state policymaking and politics on the education of America's healthcare professionals. And this history offers important lessons for the health professions and health science disciplines in the 21st century. First, that nursing was compelled to maintain multiple educational pathways has contributed to increasing numbers of racially and ethnically minoritized, rural, and low-income nursing students. This in turn has improved access to higher levels of education, particularly among underrepresented populations. For example, recent government data indicates that nurses of color are slightly more likely than their white counterparts to obtain baccalaureate or higher degrees during their careers. Nevertheless, as I said earlier, much more work remains to diversify the profession and discipline and to address racial and other social inequities in nursing. Second, as the healthcare professions are called to reckon with the racism embedded within the healthcare system and the racial inequities created by it, it's really critical that we understand how one such healthcare profession chose to construct its discipline, determined which knowledge and thus which type of research had value, and decided who would be invited to participate in that academic project. Doing so makes clear that the intellectual, structural, and political choices made by the health professions in the past, as do their choices in the present, has profound implications not only for who gets to work as a healthcare professional, but also for who has access to healthcare and how those with access experience the care they receive. In other words, the healthcare professions and the disciplines that underpin them are critical, as they have also been in the past, to challenging discrimination and affecting change in the healthcare system. Thank you.
Thank you, Dr. Tobbell, for your wonderfully informative presentation and for your book. I learned something new on every single page, and I love how you painted a picture so clearly for us that the history of nursing science is so relevant to the current issues impacting nursing science and our impact on healthcare and health of the citizens. So it's a pleasure to be with you here today. And just as a reminder to the audience to please put questions in the Q&A tab on your screen. I'll go ahead and get us started with a question, if that's okay. Early in the book, you discussed the change of curriculum at the University of Minnesota from being focused on doing to being focused on thinking. And the pendulum swung very sharply away from providing care delegated by doctors toward a grounding in behavioral and biomedical and social sciences so that nurses would be able to assess and analyze and plan for care more independently. Can you discuss how this may have contributed to nursing science as we know it today?
Yeah, thank you. And thank you, Dr. Epstein, for your very lovely words about my book. And I'm excited that you're here to lead us in discussion today. So, nursing science is still very interdisciplinary, still integrates perspectives from the behavioral, biomedical, and social sciences, integrates quantitative and qualitative research. And so I was thinking about how the best way is to answer this question. I think thinking about that nurses today, or taking that as a given that nursing science is still very interdisciplinary, but thinking also that nurses today provide care to patients in a whole variety of settings, including hospitals, outpatient clinics, long-term care facilities, as well as in their homes. And they also work in a vast variety of specialty areas. So the research that nurse scientists do is similarly diverse. And so perhaps the best way to think about how the educational innovations of the 50s and 60s what their impact on nursing science today is to think about kind of the fundamental framework that continues to guide the research done by nurse scientists. And so the way I kind of see that framework is that it focuses on the lived experiences, not just of patients, but also of families, communities, and clinicians during times of illness, disability, and health. And it centers on improving the care nurses provide and improving how patients, caregivers, and families respond to illness, disability, and how they receive the care that nurses and other clinicians provide. And also how they manage their own health throughout the lifespan. And so if we think a bit more concretely, I think it might be useful to think about kind of the research that nurse scientists conducted during the COVID pandemic. And here we see that this nursing science focused on the impact of the disease on caregivers, family members, and communities, and on the differential effects of disease among different populations, such as the elderly, the housing insecure, those already living with chronic illness, and those at increased risk of intimate partner violence. They also researched the impact of preventative measures like social distancing or delayed routine primary care or symptom management appointments on the experiences and health outcomes of people living during an epidemic or global pandemic, as it was. But they also researched the experiences of and the health impacts on nurses and other healthcare workers who practice particularly in under-resourced and understaffed hospitals and nursing homes. So here you see that focus both not just only on those receiving care, but also on clinicians themselves. And they continued this research, and as they continue this research, nurse scientists are also focusing on improving care, not only during the acute phase of illness, but also for those who, in the aftermath of epidemics like COVID-19, continue to experience the chronic effects of infection and the various disabilities that can result from them. So I think that gives us a good sense of like the kind of breadth and depth of what nurse scientists are doing today.
Super, thank you very much. We have a couple of questions in the Q&A. First, where does the development of the DNP degree figure into this history? And I think you addressed that in your book, but I'd love to hear what you have to say.
Yeah, thank you. Okay, so the DNP, so this is the latest educational innovation that was, it was formally established in the early 21st century, so in those first early 2000s. But actually, since at least the 1970s, some nurse leaders had been thinking about how to seeing kind of wanted to bring the preparation of nurses in closer alignment with other healthcare professionals, including physicians, but also pharmacists and dentists. And some early models had experimented with having even the entry-level nursing degree be post-baccalaureate. So similar to a medical school, you'd have, you as a student, you'd get your undergraduate education in a pre-nursing field, and then you would go then and do a doctorate of nursing. This actually, it was introduced at Case Western Reserve University. It had some problems. It wasn't well received. There wasn't an obvious place for those who had the ND to where they would work in the clinical setting. But over the course of the 80s and 90s, various nursing schools and nurse leaders kind of debated how the different educational needs of nurses, and particularly began focusing on how to effectively prepare advanced practice nurses. And so there had been some early introductions of equivalent to what we now call the DNP in the 1990s. But right at the turn of the 21st century, the Institute of Medicine also released a series of reports, including raising really, really serious concerns about like how to improve quality in healthcare and the needs to really transform health professions education so that clinicians were being appropriately prepared to ensure quality improvement and to make sure that this was being addressed in a systematic way. So the American Association of Colleges of Nurses and Nurse Leaders really saw the introduction of the DNP as a way to kind of meet this need. It had this kind of intellectual and kind of clinical goal of like addressing what was kind of seen as a need in the clinical space. But also, I mean, it did serve a political purpose too, because nurses, no matter how much education they got, it seemed that consistently they were feeling that their legitimacy and their expertise was too often being questioned. And for many nurse leaders, they saw this being tied to the credential. And so being able to award a terminal degree in the clinical sphere, the DNP, this was seen as kind of also a political, kind of finally being able to secure parity for, particularly for advanced practice nurses to the doctoral level. And so the DNP serve both the kind of clinical, intellectual need around improving patient care, and particularly focused on leadership, quality improvement, and kind of systematic approaches to improving those in the healthcare system. But also it did have this kind of political agenda too, this political imperative to find a way for all nurses, particularly working in academic spaces, to be doctorally prepared and to have potential parity with other clinicians. Because also by the early 21st century, it wasn't just, you know, pharmacy and dentistry and medicine. You had occupational therapists, audiologists, and others also, and physical therapists, all looking to move their education level to the doctorate. And so nurses really wanted to get parity with that. So that's where I see the DNP fitting. And it raises a lot of kind of thematic issue, brings up a lot of thematic issues, particularly this tension that I talked about in my presentation about kind of how do you, if you're increasing the educational preparation of nurses, how do you ensure that nursing remains accessible for people from disadvantaged backgrounds and those who are historically marginalized? And the introduction of the DNP did, you know, potentially exacerbate those issues around ensuring access to everyone to be able to pursue the DNP if that's what they wanted. But I think we do have much better articulation with those educational pathways now. So yeah, that's where the DNP fits.
Super.
What,
Thank you.
if I could ask a follow-up question to that I think is pertinent to some of these themes. To what extent you talk about the sort of thematic and political implications and motivations when it comes to the DNP? Just connecting that to another thread in your presentation and in your book about this tension between education and service that arises out of the project of nursing science in the post-war era. On the one hand, you have a group of individuals who are very much focused on a theoretical biopsychosocial way, as you put it, making sure that we get the health perspective right in education, as opposed to a purely disease perspective. But at the same time, then that form of education explicitly starts to be separated from the clinical setting. And so you talk about the tension here between that very strong health perspective, but then the separation in some ways from the practice setting, which then gets reified in the academic health center model that you talk about as well. So what accounts for that paradox? Because it seems like there's kind of two streams of thought at the same time that are sort of parallel but not intersecting.
Yeah, thank you for this question. So, you know, I have a couple of different approaches that I want to take to it. And the first is to say that this paradox between, if we like kind of see it as the tension between like what the academics and what's happening in the education space, and then what's happening in practice for nurses that's at the bedside clinically. This tension exists. It's not unique to nursing. It exists in medicine, but in particular, you know, exists in a lot of like practice disciplines. So in these same decades that nursing is establishing its academic status, engineering, computing, clinical psychology, and pharmacy were embroiled in similar scientific and political debates as they undertook their own academic projects. And consistently within these fields, the practitioners complained that the academics were not preparing students for the realities of actual practice. So engineers said, you're not teaching them how to actually be engineers. It's too theoretical. Those in computing were saying, we're not actually teaching them how to program. We don't need that science. So these tensions that we see in nursing, you know, it's a very common paradox. And I think that's one of the points that I think is really important to bring out, that a lot of the tensions and difficulties that nursing has grappled with over the last 60 years is also happening in other disciplines and other professions. And in fact, sociologists who study professions and disciplines have identified that disconnect between academics and working professionals as in part a core feature of professionalization and discipline formation. But then, you know, bringing it back to the DNP, I mean, I think there's been a lot more, there's a lot more support and ability today for schools of nursing to try to better balance that kind of the imperatives, the clinical with the education, and DNP prepared faculty in particular, and DNP prepared nurses in clinical spaces have an important role to play there, because they're intended to bridge that gap and to kind of translate the kind of developments in nursing science into the clinical setting, and to figure out how to kind of implement new science into that clinical space. So I think the DNP prepared nurses, and particularly the DNP prepared faculty in schools of nursing, have a particularly important role in this effort.
Wonderful. Thank you for that. That's extremely clarifying, I think, again, learning something I didn't know every single day, every time I talk with you. There's another question in the Q&A here. One audience member is wondering if you could please comment on something that Dr. Adam Biggs has said. This Adam Biggs works on the Flexner Report and Black doctors, and said that universities are designed to harm, and this participant wondered if you could comment on that.
Yeah, and I'm a big fan of Dr. Biggs' work, so I appreciate this question. Yeah, I mean, it's also a big question too. I think, you know, I have to be clear, like the history of universities has not, and particularly around the health sciences, including nursing, has not been great about being accessible spaces either for patients or for clinicians of color, and have actively, particularly, you know, in the South during the era of segregation, but even beyond that, have actively like worked to enact racialized barriers to people of color, like being students in universities and proceeding through to achieve like higher education in the university setting. And this has definitely been the case in nursing too, that there have been substantial racialized barriers to people of color, not just women, pursuing careers in higher education in nursing. And so this is harmful to for students who want to pursue nursing and then have faced those barriers, but it's also reflected in the kinds of care that healthcare institutions and those at universities have provided to patients, that we have a long history of harm. I mean, there's just no getting around it. There is like, has been violence enacted upon patients of color throughout the history of American healthcare, and the very healthcare system is like underpinned by innovations that, or knowledge produced during the era of enslavement, that we continue to kind of recapitulate in biomedical knowledge in the clinical spaces today. For example, the use of race correction, which thankfully is being pushed out. But these kind of long-standing practices that are deeply rooted in a history of racial science and structural and systemic racism have created harm, both for people who wanted to pursue careers as clinicians and for patients of color seeking care in university-based institutions. So I hope that addresses the question. I feel like there's much more I could say, but given.
No doubt. Yeah, thank you. Let's see. I don't see any other questions in the chat currently, but I do have another question for you, if you don't mind. In your discussion of the development of academic health centers, AHCs in the post-war era, and the roles that they played in the bureaucratic architecture of schools of nursing, AHCs have worked much better in medicine than in nursing. And so might this model be reevaluated in the political economy of contemporary health professions education? Is it worth taking another stab at that?
Yeah, I mean, I do think that the model has not worked for nursing, and it has worked. And I don't know that it's necessarily that, working across the board. If we think about, I mean, it's not working across the board if we think about what AHCs were intended to do, which was to create efficiencies and better coordination among the health science schools and the clinical spaces and the research institutes, that they were charged with ensuring that enough of the right kind of health professionals were available to work in the state or the region that they were, and that they were supposed to really advance interprofessional research, education, and practice. And this was language used by folks who created AHCs and were directing the leading the early AHCs in the 50s, 60s, and 70s. And we continue to hear like how we need to advance interprofessional education, interprofessional practice, and we see those limitations. And I think the fact that despite the intent of AHCs to dismantle disciplinary silos and to bring greater parity among the health professions, because previously, before AHCs, it really was the case that medicine and medical schools dominated, their interests dominated, but we still see that even after the creation of academic health centers. And in part, it's because the revenue model is that within an academic health center, the schools that were able to bring in the biggest clinical revenue or the biggest research revenue, or in the case of medical schools, both, gave that school greater budgetary flexibility, greater ability to innovate, and greater institutional power. And not just within the academic health center, but then within the university. And so like that core goal, which was premised on the kind of the political economy of higher education and the kind of research enterprise, really just kind of further cemented the greater kind of institutional and disciplinary dominance of medicine in the post-war years. And I think, if we continue to have that kind of funding model where you either have to it's really looking at clinical income or research income, you can't do that when you have schools like schools of nursing that are dependent on the tuition model. And so I think it really does call, if AHCs and health policy leaders are really serious about kind of fulfilling the intended goals of AHCs and adapting them to the needs of the 21st century, that we really need to kind of rethink those structures and how kind of what counts as being valued and valuable within the AHC model.
Well, thank you so much for that. And there's a lot more to talk about. I wish we had more time, but unfortunately we are out of time at our hour for the Medical Center Hour. I want to thank again all of our participants today for joining us on Zoom. I want to thank Professor Tobbell and Epstein as well for this high yield lecture and discussion. Please continue to discuss amongst yourselves, all participants, because there's a lot to talk about. A reminder to all our participants that you can claim continuing education credit for your participation today. Please just follow the instructions on the slides that will be shown at the end of our session today on Zoom. And please join us in about 2 weeks on March 29th, when we have our next Medical Center Hour. We will welcome Dr. Celeste Lipkes to the Medical Center Hour, who is a practicing psychiatrist, an acclaimed poet, and a UVA graduate. She will deliver our annual Ellen Moore Lecture, which showcases the contributions of clinician writers. And we're very excited to welcome her back to our Medical Center Hour space. Her lecture will be held in person in the UVA Education Resource Center at 12:15. That's again, March 29th. We will have lunch provided to our in-person participants, and we will also have a Zoom link for those who are not able to make it in person. Thank you again to Professor Tobbell and Epstein, and we look forward to seeing everyone back in a couple of weeks.